कवर के पीछे अगरबत्ती भी चलेगी।
Good morning everyone. My name is Dr. Shrikant. Today my presentation is about antidepressant Mirtazapine, also known as Remeron. Today we are going to discuss about introduction, pharmacology, efficacy, combining with SSRIs and SNRIs, prophylactic therapy and other indications, use during pregnancy and lactation, tolerability, safety, and toxicity references. Introduction. Mirtazapine is tricyclic piperazine compound was first synthesized in early 1980s, approved by FDA in 1995 for treatment of depression. Unlike most newer antidepressant, mirtazapine has virtually no effect on monoamine uptake. Instead, mirtazapine is multifunctional drug with 5 principal mechanisms of action: 5-HT2A, 5-HT2C, 5-HT3, and alpha-adrenergic and histamine antagonism. 5-HT2A antagonism improves and helps in sleep, which can be helpful in many depressed patients. Alpha-2 antagonism is another way to enhance the release of monoamine and exert an antidepressant action in unipolar depression. Monoamine transport and alpha-2 antagonism, blocking them simultaneously, gives much more powerful inhibitory signal to these two neurotransmitters than if only one mechanism is blocked. For this reason, alpha-2 agonist mirtazapine is often combined with SNRIs alone. The combination of mirtazapine and SNRIs is sometimes called as California rocket fuel because of this patient out of depth of depression. Pharmacology. Mirtazapine has half-life of approximately 30 hours and reach steady state after 6 days of therapy. Mirtazapine has linear pharmacokinetics is observed across the therapeutic dose range, that is 15 to 60 mg per day maximum. Mirtazapine is essentially completely absorbed after oral dosing, and approximately 85% will available in circulation. Mirtazapine is metabolized in liver via cytochrome P450, cytochrome 2D6, cytochrome 1A2, and cytochrome 3,4A pathways. Primary metabolite is N-desmethyl mirtazapine, which is substantially less active than its parent compound and has trivial pharmacology effect. Similarly, which inhibits cytochrome 2D6, cytochrome 2A2, and cytochrome 3A4, which raise the plasma level of mirtazapine more than 50%. In efficacy, the minimum effective dose of mirtazapine in plasma-controlled clinical trials of major depressive disorders is 15 mg per day. The maximum approved dose ranges from 45 mg to 60 mg per day. Relative efficacy of mirtazapine has been established against the older and newer antidepressants in some clinical trials. Mirtazapine found to be significantly more effective as TCAs and amitriptyline, doxepin, and clomipramine, and nortriptyline. Combining with SSRIs and SNRIs and mirtazapine. This study was performed which shows mirtazapine in combination with other antidepressant. Studies with patient documented history of non-response to any antidepressant therapy in current depressive episodes. In this study, 26 outpatients were randomly assigned to 4 weeks of double-blind therapy with either active mirtazapine or matching placebo. Examiner found that patient group receiving adjuvant therapy with active mirtazapine had significantly greater improvement in depressive symptoms than other receiving adjuvant placebo. Another study tested the hypothesis that starting patient on combination of mirtazapine and SSRIs would deliver more rapid and larger response than monotherapy. Randomly assigned 61 participants with major depressive disorders to 6 weeks of the double-blind therapy with one of 3 options: mirtazapine plus placebo, paroxetine plus placebo, and mirtazapine plus paroxetine. The group receiving combined therapy of mirtazapine obtained a significant larger reduction in depressive symptoms than group received mirtazapine paroxetine monotherapies group. Prophylactic therapies. 2 studies have evaluated longer-term treatment with mirtazapine. The first report examined the outcome of patients who received extended therapy after responding to double-blind acute phase therapy with mirtazapine, amitriptyline, or placebo. Results indicated that patients who remained on mirtazapine had a significantly lower risk of relapse than patients who continued to take double-blind placebo. Amitriptyline-treated group had an intermediate effect or outcome. The second study was formal relapse prevention trial in which 156 patients was had remitted during 8 to 12 weeks of acute phase therapy, were randomized to remain on active mirtazapine or switch to placebo. Across the subsequent 40 weeks double-blind therapy, 44% of placebo groups relapsed, compared to 20% of group receiving active continuation of the phase therapy. Other indications for mirtazapine is it can be used in treatment for insomnia, panic disorder, generalized anxiety disorder, post-traumatic stress disorder, and obsessive compulsive disorder, as well as autism in pervasive developmental disorders. A number of small studies and case series have evaluated the utility of mirtazapine in treating anxiety and depression in some cancer patients also. Blockade of serotonin receptors and histamine receptors may have particularly useful in management of anxiety and depression in cancer patients. Improvement in pain, nausea, appetite, depression, and anxiety have been reported in cancer patients. Mirtazapine used in pregnancy and lactation. In some study, 8 women were taking a median dose of 38 mg of mirtazapine per day, while breastfeeding concentration of mirtazapine or desmethyl and mirtazapine were measured in milk and plasma. All infants were clinically examined, and 4 out of them had blood-drawn clinical analysis, which shows no adverse effect on. Mirtazapine was detected only in 1 of 4 infants were tested. This study suggested that mirtazapine used lactating women is safe for breastfed infant. It is not known whether mirtazapine may cause harm to unborn baby, but a study assessed the risk associated with exposure to antidepressant. Pregnant depressed women taking mirtazapine were compared to pregnant women taking other antidepressant, and exposed to non-teratogens. Mirtazapine does not appear to increase the rate of malformations. However, the rate of prematurity was higher in mirtazapine groups compared to other pregnant women exposed to non-teratogens. Or tolerability and safety and toxicity. Side effects of mirtazapine reported during therapy are sedations, increased appetite, weight gain, and dry mouth. However, the most patients adapt this side effect without difficulty as compared to SSRIs and SNRIs. Mirtazapine therapy is associated with significantly lower rate of gastrointestinal disturbance and other incidents of treatment, emergent sexual dysfunction. Mirtazapine can provoke periodic leg movement in some healthy males. The effect was not pronounced in first few days, but gradually decreased in first week. Mirtazapine can cause withdrawal symptom upon sudden discontinuation. Symptoms include depression, anxiety, restlessness, irritability, decrease in appetite, insomnia, diarrhea, nausea, vomiting. Therefore, reduction in dose should be gradually and slowly. These are my references. Thanks.
About this California rocket.
Sir, here